Now we'll move on to Symposium 7, dedicated to rehabilitation medicine, exploring management of chronic back pain, lessons from rehabilitation practice, and promoting physical activity for individuals with impairments. I'm delighted to invite our chairpersons, Dr. Bimsara Senanayake and Dr. Gunendrika Kasthurirathne. And I would like to invite our chairpersons to introduce the speakers and panelists for the session.
Good evening. Now we move on to the next symposium on rehabilitation medicine. So we have 3 speakers for this symposium. And at the end of the talks, we would be having a panel discussion with 2 additional panelists as well. So we are going to start off with the first talk by Dr. Charitha Perera, who's a well-known figure in rehab medicine, a senior consultant physician in rehab medicine working in Australia, Flinders in Adelaide, also senior lecturer at Flinders University. So Charitha, it's over to you.
Thank you very much. Thank you for the invite. I have no conflict of interest to declare. So my topic is on low back pain. It's an important topic because most of us end up with having back pain, which is not uncommon. In Australia, 1 in 6 people will have back pain at some point in life, and 80% of them will be experienced throughout their life, and in the audience, 1 in 6 will have back pain. It is the second most common that people present to a GP, and then it causes a lot of economic burden and loss of income and poverty. So therefore, it is not only a medical, it's also a psychosocial issue that affects most of us. But the good thing is most back pain or acute back pain will recover 60 to 70% within 6 weeks, 90% within 3 months. But there's this small 10% or so that becomes a chronic back pain, which causes problems long-term and long-term disability. So what are the main causes of back pain? My talk is mainly around non-specific back pain with associated radicular or radiation of pain. There are other causes such as spinal fractures due to osteoporosis, spondylolysis, especially involving the pars articularis, malignant disease, connective tissue disease, infections, abdominal aneurysm, cardiac venous syndrome with associated bladder bowel issues, hyperparathyroidism, ankylosing spondylitis, and nephrolithiasis, and there's more. But my talk, as I mentioned, will specifically be around non-specific back pain, which accounts more than 90% of back pain that becomes chronic. So non-specific back pain, also commonly referred as mechanical back pain. It's diagnosed by exclusion and most common work-related disability in people under the age of 45. 85% of this non-specific or mechanical back pain arises from the soft tissue, which includes ligaments and muscles, and about 15% from the nerve roots, facet joints, intervertebral disc, and vertebral body. Looking at the anatomy, which is important to understand the origins of mechanical back pain, you should understand the ligaments that are involved, especially the anterior longitudinal and the posterior longitudinal ligaments, and the ligaments around the posterior aspect, as well as around the facet joints. So these ligaments do stretch and strain with our day-to-day activities or sporting activities or repetitive activities. And a lot of the pain originates from these structures. The next important area are the muscles. A lot of the erector spinae muscles with associated interspinous muscles do contribute, but there's an important muscle called the multifidus, which is well connected with chronic low back pain, and I'll be talking a bit more on this, especially when it comes to rehab. So the rest of the 15% are around the other structures, which include the vertebral bodies, discs, nerve roots, and the facet joints. So who are more prone to having back pains? People who have repetitive trauma, repetitive injuries, and sporting injuries, inaccurate day-to-day activities, improper way of lifting or twisting their backs. These people are more prone to having chronic back pain. Obesity is associated with it, sedentary lifestyle with associated poor endurance and muscle strength, smoking, and also psychological factors will contribute for the continuation of back pain and resistance to therapy. Right, so how do you get about managing chronic back pain? Most important thing is getting a detailed history where we screen the patient quite quickly, and then a thorough examination, and then you decide what imaging that you need to do. And once you have done these three things, you have a very good idea of what we are dealing with regards to the pain. And then comes the patient education. There are a lot of evidence to show that educating the patient when it comes to mechanical back pain is essential for their improvement, because they are always scared why this pain is persisting, and there are other psychological issues that are overriding. Then you decide whether you start with a conservative approach and then proceed for any intervention that's required. So back pain history, we talk about red flags and yellow flags, and what are the characteristics of the pain, and to exclude any other non-spinal mechanical problems. So when it comes to history, the main screening is to identify these two. Red flags, you have to decide whether there's associated trauma, elderly patient falling and having back pain. You'd have to exclude any fractures. Unexplained weight loss associated with cancer, any neurological signs, and especially if they are older patients coming with new back pain. And also fever, IV drug use, steroid use, and a past history of cancer. So once you ruled out the red flags, you should be able to ascertain whether this is actually, there are some other overriding psychological issues that are what we call yellow flags, which is patients avoiding activity. They are quite low mood, they are socially withdrawn, they don't do any social activities, and they believe in more passive rather than active treatment. So they want somebody to manipulate their spine or do some massage rather than them doing any exercises. And they believe that their back pain is so disabling that they require some sort of a income protection or social benefit that will stop them from working. So the next part of the history is, once you ruled out a red flag or a yellow flag, is look at the characteristics of the pain. Is the pain going down the leg, which is causing more problems than the actual back pain? You think of the radicular pain, and you can identify which nerve roots that are involved, whether it's the lumbar 3, 4, 5 or the sacral nerve roots. And you get a pretty good understanding where the nerve is originating from depending on the radiculopathy. The other characteristic is the posture. The patients who got spinal stenosis get their pain aggravated by walking and standing, and relieved mainly by leaning forward or sitting. These patients prefer to walk holding onto something like a shopping trolley when they are walking in the shopping centers, or maybe a walking frame that relieves some of the pain. So is the pain localized mainly to the lower back, radius to the buttocks, but rarely goes beyond the knee joints. These pains may probably origin from the facet joints, and these joints can be loaded by extending the back, and that will aggravate the joints individually. Once you got the history, you can go into examination, which should be done in detail, especially looking at the posture, movement of flexion, lateral flexion, and rotation, and extension. As I mentioned, extension will provoke some of the facet joint associated pain. And of course, the straight leg raise, which will reproduce some of the radicular symptoms, and then manual palpation. And also you can do a femoral stretch if you're looking at anterior lower limb pain. Once you've done the history examination, you then decide what imaging guidelines you want to follow. So generally, X-ray will be good to look at for any scoliosis or obvious fracture, but if you come to a tertiary center with chronic back pain, you've got to decide whether you're going to go for the big end CT scan or MRI. Generally, if you are suspecting associated cancer or infection, or you think some radicular pain that requires surgery, MRI is the way to go. So depending on the protocols you want to follow, you should do imaging. But the most important thing is you should treat the patient and not the scan. Interesting study done in 1990, they scanned 67 patients who didn't have any back pain. And they did an MRI scan. The MRI scan in the under 60s showed 20% had herniated disc and 50% have bulging disc. And in the over 60s, 30% herniated disc, 80% bulging disc, and 20% spinal stenosis. So it's common for some of the chronic back pain patients to come with a diagnosis rather than their symptoms. So when you ask what's wrong with you, they say, I got a L5 disc prolapse. But they don't come up with the history of a L5 disc prolapse. So therefore, you should be treating the patient and the symptoms and the clinical findings rather than an MRI scan. Now we go into what are our modalities of treating chronic non-specific back pain. It's interesting, we should look at the evidence. So looking at Cochrane reviews in 2016 and 2025, I've formulated a system which we follow in our practice. Obviously being rehab, the first one is exercise therapy. And then you can try associated with dry needling or acupuncture, injections, which I will go into in some detail, and prolotherapy, which is also a relatively new form of intervention. Multidisciplinary rehab, if you can afford different specialties, is shown to be quite beneficial. And non-steroidals are effective short-term if they can tolerate and there are no adverse effects or contraindications. Other commonly used modalities, opioids, are beneficial just short-term, especially with cancer-related low back pain. But herbal medicines, lumbar support, superficial heat, spinal manipulations like chiropractic or osteopathic procedures and lumbar support, they don't have clear evidence whether it's helpful or not. But there's a big industry associated with these modalities. Bed rest, of course, not surprisingly, patients who rested for chronic back pain did worse. It's okay to rest with an acute injury or acute back pain, not for chronic back pain patients. Right, so first I will talk about exercise. So what are the muscles that we want to exercise in back pain? We talk about the core muscles, which are muscles in the front, rectus abdominis, on the sides, transverse abdominis, and the pelvic muscles, and also the erector spinae at the back with quadratus lumborum and the muscle multifidus. These muscles do support the spinal structure and, in a way, increases the endurance of the patient or person who's doing activities. I mentioned about multifidus muscle and its associated with back pain. It's quite clearly shown in evidence. In normal multifidus muscle, you can see quite bulky muscle structure, but with the chronic, inactive chronic back patient, you can see the fatty infiltrate and atrophy of the multifidus muscle. So some of the exercising protocols we follow are targeted in these muscle groups. So what are the exercises? There's an array of different types of exercises which can be prescribed depending on the patient's circumstances, age, and their ability to perform. But it should contain both stretching exercises as well as strengthening. So strengthening can be starting with low difficulty and then medium difficulty depending on their ability. And these can be performed starting with a physiotherapist's guidance, and later on we encourage them to do them as a home-based exercise program and monitor their progress. Hydrotherapy, when available, it is quite efficacious because it helps with the buoyancy, resistance, and also varying temperature, especially when there's winter in colder climates. Doing hydrotherapy in a warmer pool helps with some of the exercises in these patients. Another modality we use is dry needling acupuncture, which is relatively quite safe procedure if the person knows what they are doing. This is different to the traditional Chinese acupuncture where you inject according to certain meridians. This is more localized injections into trigger points where muscles are actually tightened, and you try to do a deep needle penetration into those muscles and they do relax, and you can monitor their progress and encourage them with their exercises afterwards. So what are the other interventions, injections that we can perform? As I mentioned, the facet joint associated pain, the pain is localized in the lower back, into the buttocks, and rarely goes beyond the knee joint. So if you clinically find these patients have got pain arising from these facet joints, and you can provoke them with your examination, it is worthwhile trying a facet joint injection under the guidance of a radiology facility. The important part is to mention to the patient is not only an attempt at treatment, it's also a diagnostic procedure. So if you treat the correct joint and your pain's relieved, even temporarily, you know that's where it is originating from, and you can educate the patient and further plan the management. Generally, in our clinical practice, the injections may last from a couple of weeks to a few months, and some patients may last longer. But the most important thing, once the pain is relieved, what will sustain their improvement is their exercise program. So encouraging exercise in combination with these procedures is vital. So once you have diagnosed or that the pains are originating from the facet joints, a more longer-lasting procedure is the radiofrequency ablation of the medial branch. The medial branch is a small nerve that supplies the facet joint, and you can ablate the nerve through a stimulation with an electric current that will stop the impulses stop the nociceptive impulses. And this procedure will hopefully provide a longer-term symptomatic relief. Well, with your history, if you found that the patient has got radicular pain or sciatica pain, you can try using a nerve root block or a transforaminal injection into the nerve root. So these patients will have compression of the foramen and compress the nerve root, causing radicular sciatica type pain due to small disc bulges, tightening of the ligaments, or with the facet joint arthropathy. So these patients, we can try doing a into a foraminal injection into the nerve root to see if that helps with the pain. Similarly, if you got pain associated with a spinal stenosis, where the pain radiates down most of the time both limbs, you can do a epidural injection into the spinal canal. And these patients, you will find their spinal canals quite congested or tight due to the arthropathy of the facet joints associated with disc bulging and tightening of the ligaments. So these procedures are done in a way to delay any further surgical interventions that may require. And a lot of the times, they do help with their pain, enabling them to do their physical activities and exercises. I'll just talk a bit on prolotherapy, which is relatively new, but it's commonly used in sporting field. It is a method of injecting a sclerosant or irritant solution like dextrose or phenol with a bit of anesthetic to reduce local pain. And it basically tries to simulate an inflammatory response, which will stimulate, in turn, the healing mechanism of the body and strengthen the connective tissues. The thing is, you've got to repeat these injections, and because you're stimulating inflammatory response, you shouldn't be using any steroids or non-steroidal medication during that time. And using the prolotherapy associated with exercise programs have shown to improve outcomes in chronic back pain. The other evidence-based programs, including using non-steroidals and opioids and anti-neuropathic medications, are commonly used. I haven't gone into detail with these and can be used in conjunction with the rehabilitation program. Once everything fails and there's associated functional impairment, weakness, you may decide to refer to a surgery for microdiscectomy or a laminectomy. There's also other procedures such as spinal cord stimulators, which can be inserted especially for radicular pain. Cognitive behavioral therapy is also useful when it comes to understanding the pain and patient education, especially with chronic disabling conditions that are not responding to your conventional treatments. I'll briefly go through one case study just to highlight some of the clinical scenarios we may present with. So this is an actual patient, a 31-year-old female who was living with her mother, had a work-related injury in 2019 and had ongoing back and left leg pain, had many presentations to the emergency department. She's very tall, poor trunk control, and had reduced range of movement of the lumbar spine. MRI scan showed a small disc bulge, and she was treated with facet joint injection for facet joint arthropathy and also undergoing physiotherapy and was on some painkillers with tapentadol and also duloxetine. Due to ongoing symptoms, she was quite reluctant to work. There was a lot of fear avoidance, and that raised some of the yellow flags that this may be an ongoing chronic pain that will be a challenge to treat. As mentioned, we went through an MRI scan, which showed wasting of the multifidus muscle. So she underwent a rehab program with hydrotherapy and exercises. And over time, she reduced the use of opioids, and we were following up regularly. As she presented again this year with worsening acute lower back pain with lower limb radicular pain, difficulty with bowel and bladder, and weakness in a left lower limb, which raised with the history a red flag that something was going on, which is acute. An urgent MRI scan shows significant bulging disc with a partial caudate minor syndrome that required decompression laminectomy. So this shows that sometimes the patients do present with ongoing symptoms, and patients in chronic back pain can develop acute episodes that will require quite urgent surgical intervention. Well, in summary, chronic back pain is common. We must always identify red and yellow flags, which is vital not to miss any significant pathological condition. Most will get better. Once you have gone through the history examination, it is vital that we do patient education, because if the patient understands what's going on and show them in a pictorial format, x-rays or whatever you're doing, so that they understand what the pathology is and that they will be more prone to do the exercises, rather than saying you got back pain and not much we can do about it. And also important, you follow evidence-based management, because there's a lot of misleading information and businesses that are going on with the back pain management, so therefore we should always follow evidence-based management. Thank you for listening.
Thank you very much, Dr. Charitha Perera. The next topic in our symposium today is Rehabilitation Medicine for the Future Physicians, Lessons from the Past. I would like to invite Dr. Duminda Munidasa, a Senior Consultant in Rheumatology and Rehabilitation, attached to the Rheumatology and Rehabilitation Hospital Ragama, which is the National Rehabilitation Center in Sri Lanka. Over to you, Duminda.
Thank you, Chairpersons, for that kind words of introduction. And I would like to thank the President and the Council of the Sri Lanka College of Physicians for choosing this topic, especially because the rehabilitation medicine in Sri Lanka is now changing or going to a newer phase. And probably a good speaker, because I'll be becoming a history in rehabilitation medicine in this country as the newer generation comes in. So the history of rehabilitation medicine in Sri Lanka had these phases. It started as just a physical medicine for treatment, and then become a fledged as a consultant-led specialty when it became rheumatology and rehabilitation. And now we are moving to the phase of where the specialists in rehabilitation medicine will take over the full task of rehabilitating being disabled in this country. The Sri Lankan history has dating back to the ancient time of about caring the disabled in this country. The Chronicles tells us even in AD 394 to 426, we had a King Buddhadasa, who was a physician in himself, had built hospitals for cripples and deformed. And then we had this traditional medicine of using therapeutically, using the heats, oils, and manipulations for curing or looking or comforting the disabled in the country. From that ancient history, possibility, what we can call modern rehabilitation, started in 1920s, where then General Hospital Colombo started a physical medicine department using electrotherapy and massage, which was catered by nursing sisters and supervised by radiologists, probably the first interventional radiologist in this country. In 1950s, the era of physical medicine in Sri Lanka started when Dr. R. Nebuha, a Vietnamese specialist employed by the Department of Health, as there was lack of Sri Lankan or Ceylon doctors in Ceylon who were specialized in this subject at that time. Training of Sri Lankan specialists in physical medicine and physiotherapists in UK started during this era, and the School of Physiotherapy also was established. By 1960s, we had established Colombo, Kandy, Galle, and Jaffna, as well as Ratnapura, where there were units for physical medicine. As in-house rehabilitation institutes, it started, the first institute at Ragama where I work now, that was in 1970s, when they turned a previously TB's treatment unit to a rehabilitation hospital. This made, and that also in 1970s, there was a recognition it as a rheumatology and rehabilitation medicine and a consultant-led specialty, which aligned with the global medical standard of that era. The Rheumatology and Rehabilitation Hospital had many consultants who worked tirelessly to improve the disabled care and bringing to the standard it is now where I am lucky to work. I would like to mention that this had many threats and bad times where there was a lot of resistance of having this looking up disabled in this place. And one time, one of the politicians in this country came and told that they are going to bulldoze the place. And I'm happy to be here with a person who at that time led a real fight to get over this problem, Dr. Gulasingam, who was a medical officer at that time and who will be giving the lecture next after me. So I'm happy to be a co-resource person in this symposium with him. And most of what I told you up to now, the history, and most of my lecture today on history is based on this giant in rheumatology rehabilitation in this country, Dr. A.D.T.A. Stanislaus, in his speech as the president of then Sri Lanka Association of Rheumatology and Medical Rehabilitation, at the start of this millennium in 2000, in his speech, he said that future demands a single specialist to assume responsibility for rehabilitation program as a whole, both in hospital and community is something that he dreams of. And his vision took over and was followed up many of our predecessors. The concept paper for having medical rehabilitation as a separate specialty was put in 2014 by then chairperson of the Board of Study for Rheumatology and Rehabilitation for PGIM, Dr. Lalith S. Vijayarathne, past president of CCP. And here actually it was mentioned to make sure that we need separate specialties for adults and pediatrics. The pediatric college and the board has taken that up, and still it's also in pipeline. So future we'll have two separate specialties in adults and pediatric for rehabilitation in this country. The Sri Lanka Association of Rheumatology and Medical Specialists, under the guidance of then President Dr. Nihal Gunendrika, another past president of this, the College of Physicians, at that time requested then President of the College, Dr. Lalith Vijayarathne, to the support of College of Physicians to make this a reality. So Sri Lanka College of Physicians were highly involved at that time, and probably we need more involvement in future to support the newer generation of medical specialists in rehabilitation medicine to establish in this country. I'm happy that we have a co-chair neurologist here, because it was the neurologist who probably had more influence with the ministry and the political establishment that time, make sure that Ministry of Health and the PGM got convinced of need of standard on neuromuscular rehabilitation program in this country. Therefore, the interim specialist board in rehabilitation medicine was set up. It was first chaired by Dr. Padma Gunaratne, followed by Dr. Duminda Munidasa, a rheumatologist, and then presently, the chairperson today, Dr. Gunendrika Kasthurirathne. A whole lot of people work together, put up this beautiful prospectus for board certification rehabilitation medicine. You can see whole lots of names from Sri Lanka as well as Sri Lankans abroad contributed to establish this program, which seems to have worked well and bringing up a high quality rehabilitation specialists who are assuming duties at the moment in this country. So the year 2000 was the turning point, and up to now the rehabilitation medicine is now recognized as standalone specialty, and that will elevate the field to a consultant-led structured care for disabled in this country. And hopefully it will bring Sri Lanka in line with international practices. So though we started late here, but it's better than never. And hopefully the future for individuals with disabilities will be good in this country, and great focus needed for policy, training, and service in delivery. Up to now, the consultants in rheumatology and rehabilitation were able to establish these specialist hospitals or centers for rehabilitation, institutional rehabilitation care, at least one per province in this country. And there were many other outpatient departments all along in most of these districts in this country. So, call for the future physicians is response now lies with the next generation. Advance the specialty, innovate the clinical practice, and support inclusive long-term rehabilitation services in this country. So future is here. We have trained many, and some are now consultants. Some are here, some are gone abroad. But I'm sure where are they? Where were they? Even from abroad, they will help us to go forward. As our chief guest yesterday, Dr. Emeritus Professor Savitri Gunasekara, as well as one of the special guest or the guest of honors, Professor Andrew Elder, the president of Royal College of Physicians, Edinburgh, told us for future physicians to know the history is important so that they will carry on or improve the good work done and avoid the mistakes which has happened earlier. So therefore, I think this lecture could be an important one for everybody. And now it's our task to align global goals in what is called Rehabilitation 2030, initiative by WHO to have universal access to rehabilitation services, integration into health system at all levels with a multidisciplinary team approach. For that, rehabilitation services are required across the continuum of care. So we need at acute hospitals, then specialized rehabilitation hospitals in the community, and maybe even pre-hospital admission of at the site of any injury to have care for these patients to make sure that disability is less and they overcome from the disability. And this care may go into the need to, because a person who becomes disabled, sometimes the care needed throughout their life. So need to improve our community level, which is very much lacking in this country. And also to educate the acute care hospital, acute care medical wards, acute surgical wards and ICUs, where the rehabilitation specialists need to come in early and help these patients to have a minimal amount of disability so that the institutional care needed which must be very much less as the bed strength in this country is very low. So my final thoughts, the future of rehabilitation in Sri Lanka depends on dedication of the physicians of today and future. We need to honor the past contributions, and new generation need to work together to take it forward so that we can build resilient, patient-centered rehabilitation system in this country. Empower people with disabilities to live with dignity and independence. And before I end, my acknowledgement of again to Dr. ADTA Stanislaus, consultant in rheumatology and rehabilitation, who has written down, looked into the history of this specialty and written that in one of the rheumatology news, the induction speech. I would like to thank Dr. Chamara Jayatunga, the consultant in rehabilitation medicine, for sharing some of the slides with me, and to all those who contributed to development of rehabilitation services in Sri Lanka. And Dr. Stanislaus in that speech saying, I earnestly wish and pray that I would live to see the day it emerges as two distinct specialties. It has happened. He's living well today in Kandy, too old to probably travel here. And So I think we have achieved the dream for him and hope the future will be very bright for disabled in this country. Thank you.
Thank you very much, Duminda, for that comprehensive talk. Now we move on to the final talk in this symposium. I would like to call upon Dr. Sivakumar Gulasingam. Dr. Sivakumar is a physiatrist and a medical director of rehabilitation and an assistant professor of physical medicine and rehab at the University of Toronto in Canada. He actually completed his medical education here in Colombo, University of Colombo. So in addition to his clinical work and academic activities, he's actively involved in parasports through different roles in the International Paralympic Committees and so on. So I would like to warmly welcome and Sivakumar and also to ask him to start his talk. Thank you.
Thank you for that kind introduction and Dr. Duminda for those kind words. So I'll take from what Dr. Duminda left with regards to individuals with physical impairments. My topic today would be promoting physical activity in individuals with physical impairment. I have no financial disclosures. These are my current roles with regards to my work. And with regards to the topic that I'm going to speak today, I have been involved in system development and also promoting physical activity and sports from grassroots to podium performances. Outline today would be on Physical Activity 101. What is physical inactivity? Some groups at risk for physical inactivity. Effects of physical inactivity. Sports as a vehicle for promoting physical activity and health. Evidence related to physical activity among individuals with physical impairment, and promoting physical activity in sports in rehab settings. We'll also look into some barriers and how to overcome them. So the objective for today, or take-home message, would be anticipated as appreciate the effects of physical inactivity, importance of promoting physical activity in daily settings, promoting physical activity among individuals with physical impairments, and improving awareness in promoting physical activity through sports in individuals with physical impairment. We'll look into some definitions because no topic starts without definition. So physical activity means a bodily movement that produces skeletal muscles that require energy expenditure. Physical inactivity, in contrary, would be performing insufficient amounts of physical activity that do not meet the physical activity guidelines. Disability, as we all know, is a physical, mental, or intellectual sensory impairment that substantially limits one's participation in daily activities. And physical impairment could be a significant difference or abnormality in the body structure or function which affects a person's ability to perform physical activity, movement, or function normally. Types of physical activity can be a cardiovascular, resistance training, stretching, neuromuscular facilitation, or balance and proprioception training. This could be achieved through different forms, such as your regular home and work-related activities, leisure activities, and structured exercise. How much physical activity is recommended? So these are laid down by the WHO, and I do believe that most of us follow this. So for children and adolescents of age 5 to 17, it's 60 minutes of moderate, vigorous physical activity and at least 3 days a week of strength training activities. For regular adults, age 18 to 64, 150 minutes of moderate intensity or 75 minutes of vigorous intensity activities. And with regards to muscle strengthening, 2 days or more per week. When it comes to individuals above 65, the moderate to vigorous intensity stays the same as 150 minutes, but again, with regards to muscle strengthening, is considered as 2 days a week. In addition, some of the stretching and neuromuscular coordination activities becomes more important for individuals above 65. What is the physical activity statistics at present? So if you see, 23% of the adults of age 18 and over are not active enough as of 2010. And in high-income countries, it's about 26% in men and 35% in women. And if you see in low-income countries, the people are more active based on probably the mode of transport and the way of lifestyle. So the physical inactivity is less in low-income countries compared to the high-income countries where we would think vice versa. We also see that adolescent girls are less active than adolescent boys. Levels of insufficient physical activity, WHO has certain guidelines. They have tried to identify how we could overcome these things as they are part of contributing towards non-communicable disease, which is your morbidity and also with regards to mortality. Policies have been taken in place, and more than 56% of the member nations are following these physical activity guidelines. And the one over here, you could see the concept paper for Sri Lanka as well that was put down in 2018. If you see the global statistics for disability, 1 billion individuals are with some form of a disability, which contributes towards the deficiencies of their healthcare needs, how they would access, and things with regards to the cost as well. Coming to Sri Lanka, the population in disability is 1.6 million, that's 87 per 1,000. And if you see the physical impairments, it's mostly with regards to the mobility that they have mentioned as 734,000. And for ADLs and self-care, it's something like 197. All these are statistics based off of 2012. So the continuum of physical inactivity, if you would see, it's described as performing insufficient physical activity that is not meeting the specific activity guidelines. And sedentary behavior is considered when your energy expenditure is less than 1.5 METs, which is below your regular activity. Deconditioning, when individuals are forced to have or when they take sedentary behaviors, they do contribute towards deconditioning, which results in muscle mass reduction, weakness, functional decline, and also with regards to other secondary factors like comorbidities and health-related issues. There are certain groups that are at high risk for physical inactivity. That's extremes of age, adolescents, female population, natives and First Nation individuals, immigrants, and individuals with disability, individuals with chronic disease, and also some with medical conditions where there may be some myths, cultural and awareness-related issues contributing towards their inactivity. The physical inactivity has a cycle of inactivity which propagates more adverse events and effects, contributing towards the deconditioning and increased effects of chronic disease. This further increases the reduced functional capacity and continues as a cycle. It also has its ramification in different systems from cardiovascular, musculoskeletal joints, bone, respiratory, and metabolic effects. There's also an economic impact with regards to physical inactivity, and this is data from Canada from year 2015 to 2039, where they do propose with regards to the cost for mortality and disability with individuals with physical inactivity. There's overall 3.7% healthcare costs related to physical inactivity in Canada, and similar in Australia where it's 10%. And there are papers which do mention that physical inactivity and sedentary behavior not only contributes to chronic disease, but also financial costs. Again, if you see individuals who are having sedentary lifestyle, like even what we would consider as driving for longer duration, 10 hours or more per week increases the cardiovascular risk by 82% than individuals who drive less than 4 hours to work. 1 additional hour of sedentary activity increases your risk of being overweight by 13% and developing high abdominal fat, which contributes for certain other conditions as 26%. One of the important things to consider here is not the overall activity, not the duration of physical intense activity that you do per day, but overall how your performance is. So physical activity is not enough, but also needs to avoid too much of sedentary behavior. So if you would consider the two subjects, subject A and subject B, subject A is not meeting the physical activity guidelines, whereas the subject B is meeting the physical activity guidelines, which is 150 minutes of moderate intensity physical activity. But on the flip side, if you say their overall activity during the day, subject A, who was not reaching 150 minutes of vigorous or moderate vigorous physical activity, spent 75% of the day with low intensity physical activity and only 25% with sedentary activities, whereas the one who was doing 150 minutes of activity spends more time with low intensity activities. And if you see the energy expenditures per day is better on subject A. So it's not just meeting your requirement, but how you would work through the day that counts. We did see what physical activity was. And when you do the physical activity, which is a planned, structured, or repetitive movement, it becomes an exercise. And an exercise moves into sports when there is an element of competition that comes in. Competition is also a hallmark with having a reward that attributes to it. So physical activity, exercise, and sports work in the continuum of physical activity. On your day-to-day activities, your physical activity can be your regular walking, stairs, and indoor activities, moving towards aerobic exercise, recreational activities, and intense sports. And if you see the pyramid here, you would like to reduce the number of time that you spend, or number of minutes you would spend in sedentary activities, such as watching TV or playing games, and increase your activities down the pyramid. Again, activities of moderate physical intensity can be from your gardening, cycling, such as recreational activities, to sports, which can be recreational to competitive sports. Concept of physical activity among individuals with physical impairment. Most physicians, as Duminda mentioned here, some of the people involved in physical medicine and rehabilitation, or rehabilitation as such, they did see how you could improve patients' participation, and sports was considered a nice tool or a vehicle to move individuals into more increased physical activity. And Dr. Gutman, who was the father of modern day Paralympics, started the sports activity at the Stoke Mandeville Games, which initially started as archery in 1948, which transitioned into international Stoke Mandeville Games with inclusion of Netherlands, and which is now currently considered as the Paralympic movement. Similar echoes were mentioned with Invictus Games. Again, they do see when individuals participate, the war veterans participate in sports, it inspires recovery, support rehabilitation, and generate a wider understanding and respect in individuals with physical impairment. This was in Toronto in 2017. The post-game survey did show results with empowerment, optimism, power, drive, and transformation that were identified during the surveys post-Invictus Games 2017. Similarly, the Paralympic vision is to better the world for people with disability by breaking the barriers and engaging individuals into sporting activities from grassroots to podium performance. These lead to a paradigm shift from can I to I can, impossible to I am possible. And even if you see the ancient times, exercise is considered as medicine, and Indian physicians in 600 BC have already mentioned about exercise as medicine. What is the current evidence with regards to physical activity and returning of individuals with physical impairments? So this is a study done on promoting physical activity in disabled people, which does show it positively associated with self-efficiency, intention, and weighing pros and cons, and negatively associated, which means people who engage in physical activity, they feel that they're experiencing less barriers, they feel that the severity of their impairment is less. So it's a negative correlation. There's also the other intervention measures with regards to behavior changes that's mentioned here. In another study in children who were attending summer camps. They do feel that they are not alone. They feel they are independent, and their chance to discover is much more higher when they engage in physical activity. It also increases their self-reliance, independence, and understanding of their physical potential. Some of the common themes that were echoed in these studies were the unconditional acceptance when they participate in physical activity and sports. They feel that they have achieved something. They feel they have achieved a dream. They feel that they are beyond the wheelchair that they are known to, and they feel much more stronger of themselves with regards to self-confidence. The studies also came to light saying that they did not want them to be treated differently, and they felt that their emotions were managed much better. And do we need extra support for developing these type of activities? We do not need new interventions. Adapting to existing interventions and increasing collaboration itself can achieve these goals. And I do think that at Ragama Rehabilitation Hospital, we did see this. We did initiate some sports days, which included indoor sports and outdoor sports. Annually, we started hosting them. And we did see the enthusiasm of the patients during participation, during getting awards, and then having those special days. We did not have anything extra, but we used with the existing services and facilities and the sponsors. One of the important ways of messaging for physical activity would be infographics. Giving individuals with physical impairments, they may have other types of challenges with regards to cognitive or writing, reading. So infographics is considered as a good tool in transforming information. And as we heard from the previous speakers, not only here, also with the rheumatology sessions, having dedicated social workers or what we would call recreational therapists would also pave way for having a better programs, coordinating things. These are some of the words and experience appreciations that were shared by some of the individuals engaged in these grassroots level camps. We'll move slowly into the sports and physical activities. As we know, impairments could be of different variety: physical impairment, visual impairment, intellectual and hearing impairment. And I'm going to focus more here on physical impairment. What is common in these individuals? So these are the individuals that we see in the acute care following a trauma, injury, blast, or any such condition. They are devastated, their life is changed, and once they come into the hospitals and the rehab centers, they are transformed going through the rehabilitation process, whatever their impairments or disabilities are. As they move the continuum, they move towards grassroots level, participation of sports, and then move towards elite level Paralympians or elite level sports performance. We do know that able-bodied and individuals with physical impairment are different. The needs of the physically impaired individuals includes change in body composition, weight bearing, positioning changes, spasticity, altered sensory response, autonomic system, fluid hemostasis, and so forth. These are some of the conditions specific for individuals with physical impairment with no specific preference, but on alphabetical order. Autonomic dysfunction is different from autonomic dysreflexia, which is in spinal cord injuries. Heterotrophic ossification, neurogenic bladder bowel, neuropathic pain, concerns related to prosthesis and orthosis, skin issues, subluxal osteoporosis, stump-related conditions, syringomalia, and tethered cord. So these are some of the things that will involve individuals with physical impairment. There are direct and indirect impacts in sports when individuals with physical impairment participate, which can be medical, physical activities, and indirect can be cognitive, emotional, and also with regards to financial gains, benefits, self-esteem, and quality of life. Individuals who are engaged in physical activity and sports, they become more aware of their medical conditions and disability. They are better able to manage their impairments. They are aware of the alteration in training, and they are able to prevent complications and health deterioration much better. They also engage in more health promotion and with regards to working on secondary benefits. Physical activity and sports in individuals with physical impairments. I mean, developing a program to capture the health and related benefits is important. And capturing them at the most receptive period, which is a life-changing event when they are at a rehabilitation setting, would be pretty ideal. Physical activity and sports, as we mentioned, becomes a great vehicle for this transformation. If you see the child on the tricycle there, anybody know what this is called as? This is known as frame running. So individuals with cerebral palsy, they have increased adductor tone, they have difficulty in balance. So this bicycle was initially started as a therapeutic measure, similar to what they call a hippotherapy with horse therapy for children with cerebral palsy. But the organization was such strong, the parents were rallied together, and now this is the latest addition for para-athletics or para-sports, which is known as race running. So they use a tricycle, and you can see the child on the starting block. And there are 2 sports classes for these athletes. So it's ideal to identify them at the most receptive period, and we can work, a group of parents were able to bring this therapeutic activity into an international sport. The breaking the conundrum. So impaired health, we know that it loops into inactivity, deconditioning, and disability. And if we can break that conundrum at the inactivity level, if we can start with some exercise, counseling, increase physical activity, then we would work towards optimal physical functioning. As we mentioned, rehabilitation setting is ideal as they are more receptive. And the first picture there you see is at Ragama Rehabilitation Hospital when we started the sports days. Working to make a positive change is important, but the magnitude does not matter. Even small steps make a long way. Exploring the interest of the individuals with physical impairments, introducing a sports, maybe an individual coming in as a peer group. So most rehabilitation centers, what we do is every 3 months we bring in a grassroots level or an elite athlete with physical impairment and speak to the individuals, which motivates them, and also it generates lots of discussion and a positive hope. Recreational therapy is something that also is part of most rehabilitation programs, where it brings in the concept of play therapy and sports as part of recovery. Local sports events and disability days can also be a vehicle to bring in physical activity. Encourage involvement, talent identification, and direction of these individuals towards the right organizations for the next level of sports participation. If you look into the physical rehabilitation pyramid, you can see the ADL conditioning going downwards. You could see mobilize the conditioning, progressing more stabilization, cardiovascular conditioning, and then proprioception and cognitive facilitation. Some of the areas that you would look into, the skills, performance, and movement, which would work towards gearing grassroots level athlete into a podium performance. You could also see having different roles with regards to physical activity. Physical literacy can increase lifelong physical activity, sports for all programs. Some of the countries in individuals with physical impairments and schools with physical impairments have these as part of their program in school level, and also with regards to community centers where they bring in as part of recreational activities. Any change, as we know, should go with the behavioral change cycle, and that's something that we need to keep in mind. Facilitate health in individuals with physical impairments by increasing physical activity. It brings from illness prevention. So you start from acute illness, rehabilitation, illness prevention, injury prevention, health promotion, and then to optimize performance. These are some of the areas that we would work in these athletes, in bringing them from grassroots levels to podium performance. Periodic health examination, just like what we would have like regular medical examinations conducted for these athletes to prevent certain injuries and to identify any potentials for overuse injuries. Addressing barriers and inequalities. This is again based on the WHO model. Again, WHO recommends to enable access to all mainstream systems and services, invest in people with physical disabilities, and Duminda would agree that at Rehabilitation Hospital with the patient partners, even the Ragama city was made into a more accessible with regards to ramps and things at the service station, the railway station, and areas like that. Adopt a national disability strategy, involve people with disabilities, human resource capacity, increasing public awareness. We also need to have the data collection and strengthen the support for research and disability. Some of the partners in making this change would be the government, the local organizations, service providers, academic institutions, private sector collaboration, and also people with disabilities and their families. This is my experience working in Sri Lanka, and subsequently, we did have these disability days, parasports. RESTA was an International Paralympic Committee's flagship program that was carried out in Sri Lanka after tsunami, where we rehabilitated individuals from all the provinces. Going forward, I would propose increasing the awareness, incorporation physical activity to daily routine, creating hubs to promote physical activity, health screening for injuries, prevention and promotion, influence health and wellness policies for individuals with impairments. These were my objectives, these were the references, and thank you.
Thank you very much, Dr. Sivakumar, for that excellent presentation. Now we move on to the panel discussion, and I would like to kindly invite the three speakers onto the stage. And also I would like to invite the three panelists, Dr. Chamara Jayatunga and Dr. Dinushi Dikkowita, who are both rehabilitation physicians, consultants. It's my pleasure to invite them. They are both my trainees as well. And also Professor Ian Cameron, the other panelist, to the stage, please.
Okay, so we are happy to invite the audience to ask any questions from the expert panel. We have 3 speakers and 3 panelists. Any questions from the audience? Okay, so shall I start by a question from Dr. Charitha Perera? So chronic back pain is a common problem, and it's most of the time it's a difficult to treat condition and frustrating to the both parties, treating physician and for the patient. Any suggestions to prevent recurrence and chronicity in chronic back pain, especially at primary care? Maybe Chamara and Dinushi, you will also contribute by explaining how rehabilitation can contribute prevention of chronicity and recurrence.
Yes, I think prevention, starting with education. So depending on where the injuries occur. So as I mentioned, a lot of twisting, lifting activities do contribute a lot. If it's involving a particular employment or vocation, you can advise on safety in their workplace. Whereas if it's a household injuries and household activity that is causing the back pain, then of course adapting safe practices is helpful. And the number one way of preventing further injuries is keeping active and maintaining your core muscles and strength so that further injuries will be minimum. So that's my advice. There's no one magic bullet that will prevent it, but it's a combination of identifying the reason and the resources that you have to manage it.
Do you have anything to add, Chamara and Dinushi? With rehabilitation, any contribution, prevention or with treatment, chronic back pain?
So I think when you see patients with chronic back pain, sometimes they have underlying causes in addition to non-specific back pain, especially there's a bit of somatization, bit of mental health concerns. So I think it would be worth having a detailed discussion and try to identify anything which would be contributing to the chronicity and sleep problems. And sometimes you have seen patients with chronic fatigue and even certain functional disorders coming as chronic back pain. So that is one point. Second one would be, I think, posture and if there's any pelvic tilts, whether we can start a rehab program to correct to a certain degree. And one reason why it is difficult to treat is these are behavioral changes that we are trying to implement. So we might need inputs from other specialists as well.
Thank you. And yeah.
Thank you. Sue Curl from Australia. I'd like to ask the last speaker, how do you get people doing the exercise at the level that is recommended? We know what we should be doing. How do we get people to do it? And I'm thinking, although I'm a geriatrician, people of all ages, because we know how important lifelong exercise is.
As answered by the previous group, the behavioral change is important. So the behavioral change is usually done better in groups. So we do have programs for rehabilitation where we do the inpatient, then they come for outpatient, and at certain facilities, certain programs, we group the outpatient rehabilitation into clusters. So for example, at cardiac rehabilitation where I work, we do have clusters of stroke patients. So we have a stroke group, we have a cardiac group, we have a general medical group, we have a cancer survivorship group. So even the cancer survivorship group, they were coming into the regular group, but all these females got together and said that they feel more comfortable speaking about different topics if they are part of a single group. So we did start a female group or women's health group. And once they complete that rehabilitation program, they can also continue to come there as graduates, or what we call a graduate program. So it won't be a supervised program like what it would be a rehabilitation program itself. There would be less one-on-one supervision. And they are willing to pay a small fee for part of that, which is self-sufficient to maintain the program. And these groups, they usually are allotted later in the evening. So it may be a 7 to 8 o'clock or 7 to 8:30 program. So I look into this as more as a creating that group culture, group cohesiveness. That is the one that is going to take us more. I'm talking a little bit more, sorry. For the breast cancer survivorship, we have a separate program that we do. In that too, the people were grouped into groups, and when the COVID started, when we went into virtual model, the outcome was not that great because they were not being able to discuss individual discussions, so the attrition was much more higher. So I would say making that change, the group dynamics becomes somewhat important, whether it's rehabilitation, whether it's sports, or any other.
Can I just ask Duminda? I think he explained about ancient Sri Lanka and rehabilitation medicine. I think Sri Lanka has archaeological evidence for the oldest hospital in the world in Mihintale. So I think from that hospital and other ancient hospitals in the country, which is like 9th century AD, there are various medicinal baths like Jantagara, which is a steam bath and a hot water bath, Alattao, which is actually a medicinal bath, kind of a hydrotherapy, practiced centuries ago in Sri Lanka. So in that context, do you plan to involve the Ayurvedic physicians into your rehab programs in the future?
Well, yes, we have a culture where even if we don't involve, a lot of our patients will go for this type of things, like especially, I mean, you should be very, as a neurologist, you know that a lot of patients will refer to rehab, but they will first go to the Ayurveda system, do things, and then come back. But though we have this history, the scientific way of doing it, there we have conflicts. So we see that they sometimes come with more spasticity than what we would have seen if they come straight to a rehab hospital. So if at all, if you have to combine, probably need to sort of sit down and talk about the scientific basis and then go about, because sometimes the Ayurveda system in this country, the problem is not really, the teachings are not structured as such sometimes. It's sort of what they have been learned or heard from their predecessors and that so forth. So there may be some issues that we might come up, but we need to sort of, since it is there, we might be able to learn certain things from them as well. So at the moment, there's no greater plans as to combine those, but it is there, and that really we need probably the future physicians look into that and see, so that the patient will get benefit both, and some of the mistakes that, or some of the unscientific things that happen can be reduced, and they also can contribute because the patients wish to have this in this country, majority of patients, they believe in that. So those beliefs are important culturally for our patients. So if we can, possibly a good thought to combine, or to try to have a combined program where the patient will be much more adaptive for that, but probably have to look into the issues that sometimes comes up.
Can I add a point to that? So I think we all agree that rehab is best delivered with MDT inputs. So it's good to have inputs from other medical systems as well. But one point of team culture is that it has a downside. One is the lack of accountability. So if we can have a conversation, agree on a consensus, then of course that's a very bright future, I think, for a bit of a hybrid model, in my personal opinion. Especially in medical legal, and because the rehab is so vast, we will be seeing patients with medical legal concerns. So yeah, that's what came to my mind.
Could be correct, yes, Chamara. And I would like to ask Dr. Dikkowita. Now you have been practicing rehabilitation medicine as a newly board certified consultant. So what are your priorities when you consider the obstacles to go ahead? You have a huge responsibility to build up our new future. So if you prioritize, what are your most experienced obstacles?
Yeah, I'm really grateful for the history of this specialty so far. So the obstacle-wise, I think the team working is one of the core and very important thing in, particularly in rehabilitation. So as rehab physicians, we should be leading effective teams in order to have the maximum functional outcome of our patients with complex disabilities. So the team to lead, to empower the team and to improve the team working is one of the biggest challenge. So we work with the patient and the rest of the multidisciplinary team the physiotherapists, occupational therapists, speech and language therapists, prosthetists, social worker. So we need to empower our team. So that is one thing. And we need a lot of collaborative services to improve, to get the maximum functional outcome. So we have rehab hospitals, but we need other collaborative services like wheelchair services, assistive technology services, and proper prosthetic and orthotic services. So these services need to be established. So we need the collaboration from the ministry. Not only that, Minister of Health, maybe Minister of Social Services, Transport. So these need to be highlighted, and we need to, huge collaboration is needed to develop these essential collaborative services. So then we'll be at a better stage, so our patients can have maximum possible maximum functional outcome in our country.
Yeah. Can I have ask a quick question from Charitha? Now, you mentioned that mechanical backache is a diagnosis by exclusion. So does that mean that in your practice, each and every patient with mechanical backache is being imaged? Or do you stick to cases with radiation of pain or other neurological deficits, other constitutional features? When you come to, like, I'm talking about MRI, do you scan each and every patient with chronic backache before you come to that diagnosis of mechanical backache?
Yeah, the quick answer is no, we don't, because being in the Australian system, we are in a tertiary hospital, we get referrals from the general practitioners. So unless they have already performed a MRI scan, we won't have that in hand when we see them. Then the decision is whether what kind of a scan or imaging we need to do. That all depends on the clinical presentation. So if we suspect, even if you suspect radiculopathy or some weakness, you can still do a CT scan, which is cheap and easier to obtain than MRI scan. But if you suspect weakness and at some point the clinical scenario doesn't match, there's a doubt, you're doubtful of your diagnosis, certainly you can justify an MRI scan in that case. So I know some practices do MRI scans straight away with everyone, but rationalizing public health funding, we just need to have a system where we screen the patients who deserve an MRI scan. And
but do you have litigation or medical legal concerns as well when you don't scan a patient who's having chronic backache?
Yeah, everyone's got that concern whether you're going to miss a diagnosis. So yeah, being a tertiary hospital, that's sort of the end point of the treatment as well. So the GPs or whoever is going to refer expect you to perform everything. So the slightest doubt, yes, we would do that. I think Dr. Gulasingam.
So in Canada, there are specific guidelines. So if the pain is acute, 6 weeks beyond, the pain continues, then you refer to a specialist. Imaging starts there based on your history and examination. And in view of indiscreet use of MRIs, there are guidelines for family doctors, which is known as Choosing Wisely Canada, that outline certain investigations, even for osteoporosis, even for backache. So there are different areas which they do see there is indiscreet use of resources. These are laid down guidelines. And in case you have a one single miss, like what Charitha said, still you will be covered by the medical legal side, because that's what the norms of expectations are.
Okay, thank you. Before winding up, Professor Cameron, now we are low-cost setting in Sri Lanka. So what are your expert advice for us to prioritize in expanding our future rehabilitation services in Sri Lanka?
I'm a visitor, so I don't want to comment specifically, but it would certainly be understanding the population, the local population, and what their rehabilitation needs you would expect based on well-established guidelines.
Difficult question. Yes, any more questions from audience, or do you have to? Okay, right. So thank you very much for all the expert speakers and the panelists. So we are at the end of our symposium in rehabilitation medicine.
Could I now please invite our chairpersons to award the certificates and letters of appreciation to the speakers and panelists.
To Duminda Munidasa,
Dr. Sivakumar,
Dr. Gulasingam, Dr. Charitha Perera, Professor Ian Cameron, Dr. Chamara Jayatunga, Dr. Dinushi Dikkowita.
Could I now please invite Dr. Yapa Udekumar to award the certificates and letters of appreciation to our chairpersons.